All right. I think we'll go ahead and get started. So welcome everyone to our weekly orthopedic surgery grand rounds. So for today, we have the pleasure of having one of our residents, Dr. Tsay, speaking to us. So Dr. Tsay is a current fourth-year resident with our program here at UCSF. She did her undergraduate work at Stanford, where she was recruited to play varsity tennis. She played singles and doubles all 4 years and excelled at that. She studied biology and biomedical informatics. And after undergrad, she came to UCSF for medical school. She started working with our department. During her time as a medical student, she worked with the Orthopaedic group. She also worked with pediatrics on developing resources for clubfoot teaching. After her time as a medical student, she matched with us for her orthopedic surgery residency, where she's continued on her path of excellence. She is currently applying into arthroplasty. She recently gave a talk at the AUCUS meeting, I think last weekend, on what's that? Okay, well, a talk was given on behalf of Dr. Tsay's work. Yeah. And highlighting medically complex patients undergoing arthroplasty at tertiary care facilities. Today, Dr. Tsay is going to talk to us about the morbidity and mortality of being a surgeon. So thank you for speaking, and I look forward to your talk.
All right. Thank you for the kind introduction. Thank you for having me. My goal is by the end of this hour, you'll walk away with some directions and tools with which to tackle the issues raised. I have no disclosures. So this is a familiar slide. We've participated in countless M&Ms with the goal to learn from our mistakes and improve our patients' care. I think this is wonderful. However, somewhere along the way in our focus on patients, physicians' own health has been neglected. These are some quotes posted by oncologist and Gold Humanism Honor Society member Dr. Laura Vader that I'll let you read. Why must our patients' health cost us our own? In fact, I believe that the two go hand in hand. As Eleanor Brown said, you cannot serve from an empty vessel. And as Audre Lorde said, caring for myself is not self-indulgence, it is self-preservation. Turns out this is not a new idea. An entire millennium ago, Dr. Al-Razi, aka the father of Islamic medicine, wrote Akhlaq al-Tabib, which is Arabic for ethics of the physician. In this treatise, he outlined the trio of ethical responsibilities: 1, physician to patient; 2, patient to physician; and 3, physician to self. Currently, we recognize the first. We need to bring attention to number 2 and 3. So let's discuss the morbidity and mortality of being a surgeon. Here are some topics I will cover, and starting with infectious diseases. So healthcare workers have faced risk of contracting infectious disease since the beginning of time. One example is Dr. Laennec, inventor of the stethoscope. Dr. Laennec was a French physician who lived during the height of the TB epidemic, to which he lost his mother, brother, and uncle. In 1816, he invented the stethoscope, thus advancing our understanding of TB, among other diseases. In a cruel twist of fate, he ended up contracting TB himself and succumbing to the very disease that he had devoted his life to studying. Another example is the HIV epidemic. In 1981, the first case reports emerged. In the intervening years, the CDC published several sets of guidelines for healthcare workers, going over precautions such as safe handling of sharps and bodily fluids. In 1987, the AMA made a declaration regarding doctors' ethical obligations. Quote, when an epidemic prevails, a physician must continue his labors without regard to the risk to his own health. The same year, the first AIDS medication, zidovudine, is approved by the FDA. 2 years later, the CDC released guidelines that include info on how to treat needle sticks and get hepatitis B post-exposure prophylaxis. And the next year, the U.S. Public Health Service followed with a statement outlining how to get HIV post-exposure prophylaxis. So from 1985 to 2013, there were a total of 58 confirmed and 150 possible cases of occupationally acquired HIV among healthcare workers. Since 1999, only one confirmed case was reported. So thanks to several decades of progress in our understanding of transmission and treatment, today the risk of getting HIV as a healthcare worker is very small, less than 1% from a needle stick, and less than 0.1% from direct skin contact with fluids. However, there will always be another epidemic, or most recently, the COVID pandemic. In the first 2 months of the declared pandemic, frontline healthcare workers in the US and UK had a 12 times higher risk of testing positive for COVID compared to the general population. Those with reused or inadequate PPE were at further increased risk, and we've all at some point experienced a PPE shortage ourselves. A wealth of literature also demonstrates the profound burden of COVID on healthcare workers' mental health, from burnout to depression to PTSD. Sharps injuries are another major issue, particularly in orthopedics. Surgical trainees are 3 times more likely to incur Sharps injuries than non-surgical trainees, and ortho residents in one survey were 12 times more likely than the safest specialty, EM. In fact, in a survey of about 500 ortho residents, 1 in 5 sustained more than 5 Sharps injuries. This makes sense as, in addition to needles and scalpels, orthosurgeons face additional dangers such as K-wires, bones, drills, and saws. And concerningly, the majority of residents did not consistently report their Sharps injuries, citing that they felt there wasn't too much risk or it was too much hassle, that they were embarrassed, forgot to report, or didn't know what to do. The consequences of not reporting are non-trivial. In addition to HIV that we discussed, there's up to a 30% risk of getting hepatitis B. 5% of those go on to develop chronic disease, and those with chronic disease have a 20% lifetime risk of cirrhosis and 6% risk of death from liver cancer. In 2001, 400 healthcare workers were infected with hepatitis B. There's also a 0.2% risk of getting hepatitis C. The majority of these go on to develop chronic disease, of which as many as 25% go on to develop cirrhosis within 2 decades. This has further downstream serious consequences. Of all hepatitis C infections, 2 to 4% are from healthcare workers exposed to blood in the workplace. So how can we mitigate the risk of infectious disease? The first step is practicing standard precautions, such as handling Sharps safely and wearing PPE. Kevlar or cut-resistant gloves can be a useful addition and were found to significantly reduce the rate of inner glove perforations in a 1993 study done at the General during the early years of the HIV epidemic. If standard precautions aren't possible, such as in the case of a PPE shortage, then physicians should advocate for their needs, regardless whether they join a physicians' union or petition the government. Third, it's important to report occupational exposures in order to receive appropriate subsequent workup and care. Let's look again at the reasons that ortho residents did not report their needle sticks. These could be addressed via education on the risk of needle sticks and also training on institutional protocols and reporting guidelines. Lastly, and most difficult, is to bring about a culture shift in which surgeons are encouraged to report and are adequately supported in their efforts to do so. This may mean a colleague stepping in to cover the pager while the injured party goes to occupational health. And then a fourth reason surgeons may not report is due to fear of the consequences should they test positive or seroconvert later on. Will disability insurers recognize their disease as an occupational risk justifying support? Will they lose their job? In a 2020 white paper published by the Society for Healthcare Epidemiology of America, they recommended that those with high hepatitis or HIV viral loads refrain from Category 3 or exposure-prone procedures. These are procedures in which the hands are out of sight for a significant portion of time or during critical stages, with distinct possibility of Sharps injury to gloved hands. And this does include many orthopedic procedures. At present, there's limited information and little support for surgeons to understand their protections and rights and to navigate such a situation. Policies protecting physicians are needed and information made readily available. So next, I want to discuss MSK injury. An extensive body of literature shows that orthosurgeons have a higher rate of MSK injury and pain. This is unsurprising. We use heavy power tools, perform repetitive motions, and are prone to prolonged static and non-ergonomic postures. 40 to 66% of orthosurgeons have reported MSK injuries, the most common being low back pain and hand or wrist injuries, particularly carpal tunnel syndrome. Rotator cuff tendonitis, lateral epicondylitis, and knee or wrist OA are also common. Varicose veins are also common, reported by 1 in 3, with 13% undergoing surgical treatment. The most high-risk subspecialties are generalists and arthroplasty surgeons. This has a significant impact. Respondents of various surveys reported that MSK injury affected their OR performance or forced them to reduce their caseload, miss work, modify their practice, leave or retire early, or pursue surgical treatment. One survey of orthospine surgeons found that they undergo surgical treatment for lumbar and cervical disc disease at a rate that exceeds the mere prevalence of disease in the general population. So how can we prevent MSK injury? On an individual level, surgeons can maintain neutral posture through conscious efforts and environmental modifications, such as asking to change the table height. To build good posture habits, one interesting possibility is biofeedback training via wearables. These are typically accelerometers worn on the back, which vibrate on the skin when the wearer deviates from the range of comfortable posture and can easily be found online. In a multi-center pilot trial in Denmark, 112 patients with back pain were randomized to receive either 10 weeks of such biofeedback training or 10 weeks of standard physiotherapy while wearing a placebo device. The biofeedback group had significant improvements in all primary outcomes of activity limitation and pain intensity over 1 year follow-up. Surgeons can also incorporate micro breaks during which they stretch their neck, shoulders, and hands. A micro break can last anywhere from 30 seconds to 2 minutes every 20 to 40 minutes during a procedure. In one study of 61 surgeons, micro breaks improved physical performance and decreased levels of discomfort throughout the body in the majority of participants. In another study, surgeons in Germany performing complex laparoscopy were randomized to either a micro break or no micro break group. They sampled surgeon saliva at regular intervals and found that the micro break group, or the IPP group denoted by the black squares and bars, had lower levels of cortisol throughout the operation, as well as decreased pain and strain through the body. There was no significant difference in operation time. Apart from individual level interventions, environmental modifications can also be made to promote an ergonomic workplace. For instance, memory foam standing pads or automated mallet systems. We must continue also innovating to improve upon the ergonomics of existing devices. For instance, it's amazing that we're still using 100-year-old instruments such as the Hibbs retractor, which hasn't changed since its invention, and which has a handle that digs into the holder's hand. So let's move on to discuss cancer risk. The top risk factor for cancer in orthopedics is radiation. Unfortunately, there's a dearth of data on radiation exposures in ortho for several reasons. One, large sample sizes are required to detect the risks associated with low-dose exposure. 2, radiation effects may lag decades after exposure. And 3, dosimeters are inconsistently worn. Nevertheless, orthopedic surgeons are clearly at increased risk of cancers compared to the general population, ranging from breast to thyroid. Aside from radiation, orthosurgeons are also constantly exposed to bovie smoke. One of the earliest voices against surgical smoke was Dr. Lorraine Day, former ortho trauma chief at the General. She was a controversial figure who had declared that people might actually get HIV from bovie smoke. This turned out to be a false and dangerous alarm. Nevertheless, it was based in the kernel of truth. Bovie smoke is 95% steam and 5% particulate matter from cellular debris, the latter of which contains many carcinogens and not so nice sounding compounds. While the severity of risk is yet to be determined, this recent JAMA review recommended that efforts be made to reduce and possibly eliminate smoke from the operating room. So how do we mitigate these risk factors for cancer? First of all, surgeons should be familiar with the principle of ALARA to minimize radiation. Institutions must provide lead and also have it available in a range of sizes and keep it in working order. In this 2016 UCSF study by Drs. Vallone, Dr. Latanza et al., they found that lead vests that were too small or large led to higher exposure rates. Finally, operating rooms should be well ventilated, and surgeons should utilize suctions, hoods, or perhaps particulate matter filtering masks to minimize exposure to bovie smoke. So sleep deprivation may seem much less morbid than cancer, but I will show you that this is not necessarily the case. Why do we sleep? The reason why we sleep is still a mystery. It is theorized that sleep helps keep animals inactive and therefore out of harm's way during vulnerable times of day, that it conserves energy when it's inefficient to search for food, that allows the body to restore itself, which is supported by evidence that animals who do not sleep lose their immune function and die in a matter of weeks, that sleep is when the brain prunes unnecessary synapses and strengthens essential ones in order to maintain its working memory and integrate information. And finally, that sleep allows for brain plasticity, which explains why infants spend so much time doing it. Regardless of its purpose, researchers all agree that sleep is important. Sleep patterns are linked to longevity, with one study of Asian adults showing that getting 7 hours of sleep for both men and women is linked to lower all-cause mortality, including mortality from cancer and cardiovascular disease. Sleep deprivation has many consequences that ultimately lead you to a worse doctor and for your health to suffer. A quick dive into a few of these. A 2022 study by Hillel et al. Compared 36 sleep-deprived residents finishing a 26-hour sleep to 31 fresh residents about to start a new shift. Both groups were assigned computerized tasks to test different aspects of empathy. The sleep-deprived residents had similar ability to accurately assess others' feelings, but had significantly less affective empathy for others' pain. The researchers also retrospectively reviewed the EMR and found that ED doctors on night shifts had a statistically significant 1/3 decreased odds of prescribing opioids to patients when compared to those on day shifts. Let's talk about motor vehicle crashes. Being sleep deprived for 24 hours has been shown to be equivalent to have a blood alcohol content of 0.10% with regards to tasks such as reaction times, eye tracking, and attention. This exceeds the legal limit for driving, which is 0.08%. In 2016, the AAA Foundation for Traffic Safety analyzed police-reported crashes over a 2-year time span and concluded that the chances of a car crash increased with progressive sleep deprivation, with 4 to 5 hours of sleep leading to a 4 times increase in risk and less than 4 hours leading to over 11 times increase. And that's when compared to drivers who slept 7 hours or more. Other industries have recognized this as a problem and addressed it via duty hours limitations. This is the case for the federal aviation industry, where pilots are restricted to 8 hours of flight time, 14 hours per shift, and 10 hours of rest between shifts, as well as the commercial motor vehicle industry, where drivers are restricted to 10 hours per shift, 60 hours per week, and 8 hours of rest before shifts. So how have duty hours evolved in medicine? Here's a brief history. In 1897, Dr. Halsted introduced the first surgical residency in the U.S. at Johns Hopkins. Trainees competed with one another for an indefinite time period before progressing to the next tier up the pyramid of graduate responsibilities. Some historians theorize that this model was self-serving, allowing him to actually hide his cocaine addiction by creating a self-sufficient team of residents to run the hospital and minimize the amount of time he personally spent there. Nevertheless, these became the foundation for residency as we know it. In 1984, the Libby Zion case sparked pressure to change. Libby had gone to the ED for a viral syndrome and died the next morning. She had been prescribed medications contraindicated for concurrent use by an intern who had been awake for over 18 hours. There is an ensuing investigation, and the grand jury report recommended work hours limits for residents. In 1989, this resulted in the Bell regulations, which created 80-hour work weeks and 24-hour shift caps for New York surgery residents. They were met with immediate resistance from the medical community, who feared that they would compromise continuity of care and resident education. However, the public was in support, believing that they would reduce adverse patient events. In 1999, the U.S. healthcare system had a watershed moment when the IOM published To Err is Human. This book broke the silence around medical errors and rather than pointing the finger at individual physicians, called for a systems change. In 2003, the ACGME published the first nationwide duty hour standards, largely following the New York regulations. These were revised in 2011 and remain in effect today. So how effective are these duty hour limits? An ACGME survey of interns showed meaningful improvements in self-reported health and safety, including increased sleep duration, a significant 24% reduction in motor vehicle crashes, 44% reduction in near crashes, and 46% reduction in percutaneous injuries. However, a systematic review found no improvement in patient outcomes. So, while the optimal solution remains a work in progress, some positive changes that have been brought about by the duty hours have included a rising utilization of adjuncts such as APPs or hospitalists to offload workload, particularly tasks with lower educational value, such as answering patient phone calls. Other solutions to sleep deprivation include safe ride home programs to get residents off the road on post-call days. I've unfortunately not personally had success using these programs. Let's change gears a bit. When it comes to maternal health, orthosurgeons experienced a host of disparities compared to the average mother. The majority intentionally delay childbirth, having their first child on an average 8 years later than the general population at age 33. Infertility rates are high, although comparable to the general population for a similar age, suggesting that this is mainly due to advanced maternal age. Pregnant orthosurgeons experience significantly higher rates of pregnancy complications, congenital anomalies, and miscarriage. And the majority who suffer a miscarriage did not inform their employer, returned to work immediately, with up to 38% suffering PTSD. The two top risk factors contributing to these worst maternal health outcomes are advanced maternal age and the stressors of working. Female orthosurgeons are more likely to work 60 hours a week than other female surgeons, and one study found that this was a risk factor for preterm labor and delivery. Insufficient maternal leave is also a risk factor for burnout. So advanced maternal age is largely the result of surgeons delaying childbirth during training due to barriers such as difficulty balancing clinical and maternal duties, a fear of how they would be viewed by others, and the perception that they would be unable to obtain sufficient peripartum care due to an unpredictable schedule. Residents surveyed were also dissatisfied with the length of maternity leave and lack of formal leave policies, and over 1 in 10 in this study considered quitting due to these difficulties. So what is the current state of parental leave? Well, the U.S. is one of 2 industrialized countries without a federal paid parental leave policy. The Family and Medical Leave Act of 1993 requires 12 weeks of leave annually, but this is unpaid. Ortho attendings only utilize a small portion of this, reporting an average of 7 weeks of maternity leave. As for residents, leave policies are confusing and issued from a spate of different organizations, with the most recent being the 2021 ABMS Progressive Leave Policy, which allows for a 6-week leave without needing to extend training. Residents currently do take an average of 6 weeks of leave, which is an improvement from 4 weeks in 2012. There are also no antepartum restrictions in the U.S. Pregnant attendings and residents often work on an unmodified schedule up until nearly labor. And finally, there's a lack of support for pregnant surgeons. Half of surgical residents stopped breastfeeding sooner than they wanted to due to a lack of lactation rooms, and a shockingly low number of Gen Surg residents were aware of parental leave protocols. I tried looking up the parental leave policy for UCSF surgical residents and found the website to be a little confusing and complicated. It appears that we get 4 weeks of paid parental leave. Reading more closely, it appears we can take up to 6 weeks paid leave by combining vacation and sick days. I did find, though, some online resources to help navigate the lactation rooms at UCSF in the general. We also have a fertility and family forming benefits program for residents and fellows through CARET. And how does the U.S. compare to other countries? So this is an abbreviated chart that I put together. In the U.S. and Canada, surgeons get a whopping 78 weeks of leave, and at least 39 weeks of that is paid, including for residents. This info can be found online. Generally, this is true time off. However, residents may need to extend their training to satisfy requirements. A significant number do end up utilizing leave. In the UK, there are also multiple programs to help mothers transition back to work, including keep in touch days during which they work and are paid, a structured return to work initiative that includes a period of enhanced supervision, professional coaching, and funding for refresher courses, as well as the option to return to part-time work. However, anything taken to an extreme has its downsides. Several countries have work restrictions for pregnant women, with the most restrictive being Austria, where women cannot work for 9 weeks before and 12 weeks, 8 to 12 weeks after birth. As a result, women end up taking far longer parental leave than men, need to delay training, and are put at a professional disadvantage. Due to this, many wait until as late as possible to disclose their pregnancy, potentially putting themselves and their child at risk as they cannot implement safety precautions. And there's actually a push for reform to allow Austrian surgeons to work while pregnant, as studies there, unlike in the US, show no difference in complications between pregnant surgeons who are operating versus not operating. Researchers theorize that this is because in Austria, surgeons do not delay childbearing as much and so are younger and healthier. So to summarize, these are some solutions for improving maternal health, which include destigmatizing pregnancy, standardizing policies for parental leave, advocating for a paid federal parental leave, allowing modified work schedules, considering extended leave options, supporting return to work through programs and resources, and making all this information public and easily accessible. So unfortunately, mental health issues are prevalent in medicine, and specifically orthopedics. Orthosurgeons suffer high rates of burnout, psychological distress, moral injury, and unfortunately suicide, accounting for nearly a third of surgeon suicides from 2003 to 2017, which is the highest rate of all surgical specialties. Substance use is also a major problem. A 7,000-member survey of the American College of Surgeons found a prevalence of alcohol abuse of 14% among males and 25% among females. In a survey of orthopedic residents, 61% met criteria for hazardous alcohol use, and 7% used illegal or recreational drugs in the past year. Among surgical residents who died by suicide, 42% were found to have intoxicating substances in their body at death, and surgeons are 1.5 times more likely to have used alcohol before dying by suicide than the general population. This March, Dr. Cunningham, the president of the Association for Academic Surgery, came out about her own mental health struggles after a year of intensive rehabilitation, using her platform to destigmatize such discussions. I wanted to show you all a clip from her address, which in large part inspired this talk.
Yes. I was the top junior tennis player in the United States, won the Junior US Open, and was ranked top 50 in the world professionally at the age of 16. I competed at Wimbledon 5 times. I'm an associate professor of surgery at Harvard. I have an R01. I'm the proud president of the AAS. I'm also human. I'm a person with lifelong depression, anxiety, and now a substance use disorder. None of my professional successes have protected me against this. I'm not special. Vulnerability is the emotion that we experience during times of uncertainty, risk, and emotional exposure. I know that giving this address today will change my career path. There will be jobs that I am not offered. There will be doubts as to my abilities. There will be people who see me as weak, emotional, and damaged. Although I am going to share deeply personal things about myself, this is not about me. I've made the decision to share my story in the hopes of using this opportunity for good. If I can prevent one of you or one of our colleagues from dying by suicide or suffering alone, it will be worth it. That is why I'm doing this. There will be death.
So mental health deserves a whole talk for itself, and I definitely won't be delving as deeply as the topic deserves. However, I do want to show some potential solutions. First of all is time. Many solutions that are assigned to the individual aren't actually feasible if those individuals aren't given protected time. Ultimately, therefore, these are actually workplace and societal level solutions. Check in with your colleagues. Listen, don't judge. Our profession must treat physician suicide as a never event and devote the same resources to it as it devotes to the never events of its patients. Our professional organizations should form committees devoted to physician suicide and issue guidance statements and resources following in the footsteps of other specialties. Know what resources are available. At UCSF, there are confidential counseling services for staff, as well as an emotional and mental health support app for residents. And finally, we need to have laws that protect physicians from retaliation. Many surgeons may fear losing their license or other punishment, and therefore do not seek help for substance use disorders until it begins affecting their performance. I want to draw attention to a little-known resource called Physician Health Programs, which Dr. Cunningham discusses in her speech as well. PHPs are state programs with a twofold mission: to protect patient safety, but most of all, to support physicians with potentially impairing conditions, including substance use, psychiatric, behavioral, and medical disorders. Physicians with substance use disorders that are classified as severe need to sign a 5-year monitoring agreement that entails random drug tests, support groups, and quarterly evaluations by healthcare professionals. PHPs are confidential and offer a therapeutic alternative to disciplinary action and are supported by the state's medical association. They are also very successful. 81% of PHP participants successfully completed their 5-year agreements, and 79% continued working without license restrictions. 88% continued participating in 12-step programs on their own after the 5 years. And nearly every state has a PHP, and you can use this QR code to look at the list. Unfortunately, California does not actually have a PHP currently. It shut down in 2007, and the current program in place does not protect from medical board disciplinary action. Neither does it provide individualized monitoring plans. Plans for a new PHP in California are currently in the works. The Lorna Breen Healthcare Provider Protection Act, passed in 2022, establishes other measures to reduce and prevent mental health conditions. Dr. Breen was an EM physician who died by suicide in 2020 in the midst of caring for COVID patients and getting COVID herself. She was afraid she could lose her license if the medical board found out she had mental health issues. Thanks to the legislation passed in her name, in May, 21 state medical boards changed their medical licensing application to no longer ask broad mental health or substance use questions. I encourage all to use this QR code for the Heroes Foundation website, which has a host of mental health resources. And lastly, I want to touch upon workplace violence. This is becoming the all too unfortunate reality. Violent attacks against medical professionals have increased 63% from 2011 to 2018, according to the Bureau of Labor Statistics. The health sector has the greatest rate of workplace violence injuries, accounting for a quarter of all workplace violence. According to the WHO, up to 38% of healthcare workers suffer physical violence at some point. And risk factors include the intense emotions experienced by patients and their visitors, as well as factors that exacerbate these emotions, such as healthcare staff shortages, hospital overcrowding, long wait times, inflexible visiting hours, and language barriers. These have all become exacerbated during COVID. Workplace violence has significant negative effects. It may lead healthcare workers to experience PTSD or moral injury. It can even lead to a decline in the quality of care, increased absenteeism, or early retirement. This only further exacerbates staffing shortages, which itself is a risk factor for further violence, creating a vicious cycle. Furthermore, healthcare worker victims are often afraid to speak up because they fear they may be labeled as incompetent or that it could lead to further violence from the perpetrator. It is important to note that patients do not necessarily need to be physically or outwardly violent to cause psychological harm to providers. This can occur in more subtle ways, such as through microaggressions in which patients challenge providers' race, age, or training, hostile behavior, verbal or emotional abuse, cyberbullying, or cyberstalking. Solutions to workplace violence include engineering control measures, such as having security officers nearby, installing metal detectors and cameras, and improving lighting. This could also include restricting entrances and having clear exit routes, as well as mechanisms to flag hostile or abusive patients and either transfer them to a different area or provider. This also includes administrative measures such as safety trainings, mandatory timely reporting programs, trauma crisis counseling and debriefing resources, as well as a zero-tolerance policy for workplace violence. In healthcare, we often have a mentality of the customer is right, where we try hard to resolve conflicts and dissatisfactions with patients. But if a patient has unreasonable expectations, become hostile, or have caused repeated psychological harm to staff, at what point is the line drawn? So Title VII of the Civil Rights Act of 1964 prohibits discrimination and calls upon the employer to put a stop to harassment. This extends to healthcare as well. In Gardner versus CLC, Ms. Gardner, a certified nursing assistant, sued the community living center where she worked for failing to address the hostile environment created by a patient's physical and verbal harassment. The court ruled in her favor and stated that CLC could be liable for any harm that Ms. Gardner suffered. In a similar vein, upstream policies are crucial. In 2020, Maryland and Pennsylvania passed bills stating that healthcare workers do not necessarily need to display their full name on their badge, which may put them at risk of stalking or cyberbullying. In 2021, a Rhode Island bill created policies for workers to file safety complaints, protects those workers from retaliation, and mandates facilities to identify workplace safety hazards and provide assault prevention trainings. In 2022, Louisiana passed several bills. One designates battery of healthcare workers as a new crime of violence, and another requires facilities to display signs stating that violence against healthcare staff is not tolerated and could result in a felony. Many of these laws are made possible by professional organizations such as the American Association of Critical Care Nurses and physicians unions such as SEIU and the United Nurses and Allied Professionals. So we've covered a lot of ground. I do want to summarize the main takeaways. In terms of what you can do to reduce the morbidity and mortality of being an orthopedic surgeon, first is to be aware of the existing solutions at your workplace, institution, and state, and apply these to your practice. Next is understanding the unaddressed needs and working to close the gap. This can be through research or advocacy and collective bargaining by joining a local work group or physicians union. Finally, you can do your part to spark culture change and dispel the stigma and opacity surrounding issues like mental health and substance use that prevents many from seeking the help they need. You can do this by simply starting discussion, directing your colleagues to the appropriate resources, and obviously treating others with kindness, keeping in mind that we are all people first and that physician-centered care goes hand in hand with patient-centered care. So these are my citations. I want to take a moment to remember my friend Max. He was the most vivacious, kind, and life-filled person I knew, as well as an aspiring ophthalmologist with whom I was lucky enough to go on many unforgettable adventures with. Sadly, we lost him far too soon to suicide. I hope that we can take care of one another in the way that Max took care of his friends, patients, and colleagues. And finally, thank you to the support system that has gotten me through residency so far. to my co-residents who have my back, and to the faculty who have supported me professionally and personally, and to Dr. Diab, the Save Our Souls Society, and Dr. Cunningham for inspiring this talk. And happy to take any questions.
All right. Thank you for that great talk. And I think we have some time for questions. If anybody has thoughts or comments? Dr. Diab?
Thanks, Alan. Well done, and well done giving us solutions. So it's not just a complaint session. And to the residents, take care of yourselves and take care of each other, and don't end up old and aching and just worn out like me. But when I was thinking about, you ended with culture, and then at the beginning you had that as well. And I was thinking about the work hours conversation, and what the messaging I receive from people who talk about it, faculty and others, is, well, it doesn't seem to change patient outcomes. It's about a bunch of complaining about nothing. We can't prove that it makes any difference, but it makes physicians happier. And I think that's important, and we don't talk about it enough. You are today. But after reading about everything, are you optimistic that you can have a culture change where we won't judge physicians for wanting to be happier?
I think that's a hard question to answer. I guess subsequent conversations will be illuminating on this topic. But yeah, I would say that there's definitely been a lot of changes, that have generated some positive effects, like at least within the duty hour realm. And so, I think that it's kind of been shown that while initially there was some hesitance around it, people are continually reevaluating their ideas.
So do you think young people like you will judge other physicians less than we have done? So if you take time off, you're not weak. If you don't, you know what I'm saying, that kind of thing. Do you think based on what you were reading, there are a lot of new bills coming out. So clearly there seems to be some kind of way. Did you get that sense, or do you think it's just going to be a blip and then we're going to go back to, work your ass off and show up and don't complain?
It's hard to assess the reception based on just reading papers. So I can only make a comment based on, objectively what new bills are coming out. And I think the fact that there are more folks paying attention to this, like even for workplace violence, the fact that there are laws being passed in response to violence against healthcare workers, I think tells me that people are trying to make culture change.
Thank you, Alan. That was really great. I have one question, just a clarification on the slide of leave. You said 78 weeks. 78 weeks for parental leave? So is that like a year and a half?
Yeah.
Wow.
I'm trying to find that.
Wow. Okay. Okay. But my actual question was about Bovi smoke.
Okay.
We've been, I feel that over the past 3 years, we have these trials in the OR where we trial this suction Bovi, for like a couple of weeks, and then it goes away. And then 8 months later, we're trying a different one, and then it goes away, and it never sticks. But every time we're using it, someone will say, "Oh, did you know that Bovi smoke is like smoking a pack of cigarettes a day?" Did you find any data on that analogy of Bovi smoke in the OR and any sort of comparison to smoking cigarettes?
Yeah, I didn't directly look at studies that claim that, but my guess would be that they are extrapolating based on the compounds found within Bovi smoke on analysis.
Uh-huh.
But I think in reality, the reason there hasn't been a direct link found between Bovi smoke and carcinogenesis is because in reality, you're taking in variable amounts based on how close you are to the field. And there are a lot of variables to analyze. Yeah, we stop.
Well, first of all, thank you so much. Obviously, I think for me, this resonates tremendously. Dr. Cunningham's speech, enormously powerful. Where is she now?
To my knowledge, she is still, continuing to engage with rehabilitation and still practicing. And in her speech, she said that, or I think in the article, she said that she was happy to see that she did not actually get the kind of retaliation that she feared she would. And people have been sending her notes, thanking her for speaking up about it. And actually I was like reading just the comments on her speech, and there were a lot of non-medical folks who thanked her for being honest and kind of reaffirmed that they still think that this makes her a better doctor.
Going off of that and kind of Dr. Diep's point, do you feel like reaching out more to the public and getting the public behind some of these changes instead of within our own community that's kind of wrought with hierarchy and years of systemic kind of cultural issues on that front? Do you think really tapping into the public is a route to do this, to continue to make these changes?
Yeah, I think that's a good point. I think, for instance, the Libby Zion case was an example of this, because Libby Zion's father happened to be a prominent former federal prosecutor, as well as a New York newspaper columnist. And so he was actually the one who began this investigation. And then there were folks in the political sphere who rallied public support around this. And it was really the public that felt that this was dangerous, not the medical community. So I think what the public can offer is an outside perspective on our field. But I think it also takes buy-in from people within the medical community too.
Thanks, Ellen. Such a great talk. I think watching this talk, one thing I realized too is that I think, especially in ortho, there's so little redundancy in our system, so that you're really kind of forced to always be available. And if one person goes down, for whatever reason, whether it be mental health, sickness, kids, whatever, there's no real way to fill that gap. So the person who's going down feels horrible on top of whatever issue they're going on, and everybody else is left kind of scrambling to fill the gap. Have you found any research or programs in which certain residencies have done a better job at filling those issues, whether it be moonlighters or some type of other system to bring in people to help fill those gaps? Because I think that's a real pressure point in our system as ortho.
Yeah, I think you bring a good point. I think because the ortho field is so small and every program is changing and different, there aren't necessarily any published literature I was able to find on this. But just anecdotally, I know there are places that may have an admin person that's solely devoted to finding coverage, which still may not resolve the issue of having coverage available. And then there are varying levels of APP support, which I think is really the only feasible solution I can think of as backup. And that is something that has trended upwards, the utilization of APPs, since the advent of duty hours rules, because programs have been, they've been the ones responsible for figuring out how to actually comply with them. And APPs have been one tool.
All right. Any other thoughts or comments? Otherwise, I think we'll wrap up there. But Dr. Tsay, thank you so much again. And thank you all for being here.